So it has been a really wonderful visit. This morning is framed as a workshop, but I have to tell you it's only a little bit of a workshop. So the first half of the morning is not really a workshop. It's more about situating the whole context of coaching. And the context of coaching is linked back to a program that JBI runs, which is on clinical leadership. And clinical leadership is vital for nursing. We normally think about leadership and clinical leadership as based on clinical competence. Highly competent clinicians get promoted to leadership, right? Do they get taught leadership skills? Not always. Sometimes clinicians get promoted to leadership, asked to become a leader, but we don't always equip them well for leadership. So you can be a highly competent clinician, perform well, enjoy the entire experience, but actually not have been well prepared for the new role. The new role is leadership. This is about helping people move their thinking, their quality, so this is a different skill set. And so I think talking about coaching, think a little bit about yourself now and in the future, but especially think about your colleagues now and in the future in terms of how maybe together we can grow the profession of nursing a little bit more. Okay, so where we would like to get to in this session is to look together at some of the theories and concepts related to coaching in healthcare. Um, and the goal is to leave with some ideas and advice on coaching strategies that you could use. We're going to really only actually focus on two. So lots of talking, but actually two core strategies together. And uh, because it's a 3-hour session, we'll probably have a little break in the middle as well. So we're going to look at the processes and models. Before we do that, we're going to look at what is the evidence base? How do we understand different approaches to coaching? And is there some way that makes coaching relevant to you, to your leadership style? And also do some group work together on action planning to develop coaching strategies. I'm Australian, so I've played a lot of sport in my life. Uh, who's played team sports, team-based sport? Who's played a team sport? Two of us. No one else has played team sport. What about individual sport? Individual sport? What did you play? Coach, did you have a coach in? Okay, who else has played a sport where they had a coach? Anyone? Oh, lazy.
They have no time.
No time for sport. Yeah.
PhD student, you go to the gym. Is that? Yes. Yeah.
Whoa. So you must have some good stories about coaching in the gym. Like if you have good form in the gym, you're safe, you're effective, you get so strong. But what happens if you have bad form in the gym? What happens? What's the risk from bad form? Someone tell me in English. Don't be scared. I think round of applause.
What? Now everyone wants to reply. One question.
So for those online, what we just heard is that if you go to sport or gymnastics and you have good coaching, you have good outcomes, it's safe, you achieve your goals. But if you don't have good coaching, you risk injury, muscle tear, damage. Now, I'm going to tell a small story and it will take a few minutes, so please be patient with me. The picture on screen here that you see now is got a red circle. This is where I used to live. This town is about 800 kilometers away from Adelaide if you drive. The total population in my town was about 30 people. It was very, very small, very typical rural, remote country Australia, where, sorry,
30.
30 people, 30. Yeah, 30 people. Very, very small. It had one shop, only one shop, and that shop sold everything you needed for life. So, uh, country people play lots of sport, and I played football because that's what you do in country Australia. And I was young, but all my teammates were farmers, and they were old and fat, mainly, not fit. They played football really for social, not not because they were like, whoa, hunky, strong men, right? They were just farmers. They sat on a tractor all day, and then on weekend they would come out and try to kick a ball. Not very good. We had a football coach, and he used to yell a lot. He would yell at us to motivate us. Is this like nursing in Thailand? They yell at you to motivate. Don't answer that question. So he would yell before the game. He'd get us all together and yell at us. And then he would yell during the quarter time, halftime breaks, try harder, come on, get in there. He was really good at yelling. And then after the game, he'd be very quiet, mainly because we would lose every game. In fact, I played football for 2 years and we did not win a single game. Zero, nada, nix. We never won a game. And there was something interesting about moving to the country and playing football. I had never played football until I moved to the country. And my coach, with all his yelling, with all his passion, with all his intensity, he never taught me one thing about football. I didn't learn anything from him. His effort was 100%. His effectiveness was zero as a coach, right? So lots of noise, lots of posturing, lots of drama, zero impact on my ability to know the game and to learn how to play it strategically. So if we want to be coached or to coach, we need to think about a few things. Uh, we've got to recognize why people are there and what they know. And if we don't do that, we're never going to get the right result. So my coach used to yell things like, try harder, be fit, like run more, run, build your endurance, kick the ball better, be better. But be better how? How am I going to be better? What skill? And how do we break that skill down so that I can practice the components of the skill? He never did this. So all his energy, his anger, and his passion were completely wasted because in 2 years we didn't win a single game. And I think the lesson from this is verbs like doing words, be better, try harder, get up earlier, work. These are not coaching, right? These are just verbs. Verbs are not coaching. Telling someone to work harder, to put in more time, making motivational sayings and putting them up on the wall, those are not coaching. So we want to, I guess, establish a few things this morning. Here's sort of where we're going to go and how we're going to get there. So a little bit of framing. So you can see, I think probably around about 10:15, we should probably stop and have a short break and wriggle. And then we'll get back into, you don't have to wriggle, but move. And then get back into the program. And nominally we'll wrap up about 12, but hopefully a little bit before then. Good morning. Good to see you. So, no, it won't be mean. All right. So there's lots of different things that we can talk about and use in relation to growth and development, because all of this technically is about growth and development. And I don't know the extent to which these things are truly separate, but we try a little bit to distinguish, for example, between mentoring and coaching. And people will say that, for example, mentoring is more about longer term relationships, which is where somebody who's more experienced or a senior leader will guide somebody who's newer or more junior in ways that help reduce their stress, improve their development, their professional development. And mentoring is useful in healthcare because organizations that practice mentorship can reduce staff loss and attrition. So it's useful for retention and recruitment strategies, and that can minimize turnover of staff because staff feel supported when they're seen and engaged with. So some people say, well, I haven't got teaching on screen. Mentorship is about the longer term, career guidance, that kind of thing. Whereas coaching can be seen as more short term, more goal orientated. And it's potentially using standardized processes, frameworks, or rubrics to help develop somebody with specific capacity needs. So there is an opportunity here to just quickly check in. Has anybody had mentoring before? Professor Patraporn has. You have? Do you have? How did you find being mentored? What was it? Was it like this long-term relationship with somebody senior who guided you?
In fact, not really formal mentoring, but it's like a senior faculty who be like help me and mentoring me for my teaching. And now she still continue to be my mentor whenever I have some some unclear or some problem regarding a supervised nursing student or guiding for the dissertation project,
Yeah.
or maybe unclear some point. Or also another one is maybe like my personal life as well. So she still be continuingly to give me not really give the direction what should it be, but tell me it's what is the advantage, disadvantage, and then you can make decision by yourself.
Yeah. Okay, so that's a great example of mentoring, isn't it? I think that deserves a prize. What's the little prize? All right. If you're online, I'm so sorry, we have no prizes to give you. And then coaching, is arguably a little bit different. I think the difference is a little bit like research and quality improvement. Some people try to highlight the differences. Some people argue for the similarities. I actually don't think it's important that it's really defined as super different. Like pick a style that works for you and works for the person. And if it's too similar to mentoring, doesn't matter, right? But we're going to go through some models that will help define and clarify some of these things. So coaching can be good for leadership development among managers, can assist with specific domains like knowledge, behavior, skill, attitude, and practice. And so summatively, we could say that teaching is about instruction, more maybe about technical skill acquisition or knowledge deficit replacement, right? So those are a little bit reductive, directive, telling, giving, and we can test teaching efficacy in a number of different ways in order to fill a gap in skill or knowledge. Mentoring is arguably more about opening doors, making suggestions, advice, and broader framework guidance around how an individual might enhance or progress part of their career or part of their attributes. And coaching, you can see here, asking significant questions, lots of listening to understand where the person is coming from. So my experience of being a coach is with a senior research fellow at Adelaide University. And we meet for coffee every couple of months. And I ask him open-ended questions and I jot down the answers. So we meet for an hour and I really spend a lot of time listening, not too much time talking. But I get him to explore not just the problem or the idea, but the solution or the pathways that could come out. And then I go away and actually I don't, for the next half hour, all I do is read the notes and reflect on them. And I create themes of those notes. And the next time we meet, I feed back the themes. So it's high level. It's not telling him detail on how to do A, B, or C. It's coming back to the concept that he raised. And we work through those themes at each subsequent meeting. So I'm encouraging him to broaden his thinking by asking the underlying framing questions that move him along. All right. So we've heard a little bit about, so maybe I won't ask this because we've sort of heard about experience already with coaching for sport and mentoring as well. But I guess there is a line of thought here that we should consider. Not so much what has your prior experience been, but could you see coaching being part of your future career progression and development? And if you could, what kind of coach would you like? I want to ask you all to do something we won't share this. This is private, okay? So I just want you to write down or put on your computer or your phone 4 or 5 characteristics like that you would like to see in a future coach. Just do it quickly, like don't think about it too much. 4 or 5 characteristics of the coach, of a potential coach. Yeah. No, for themselves to be coached. So what would your ideal coach be like? And you notice I use the question, what would they be like? Because coaching is interpersonal. And now that you've written those down, write down, including online, please do this online. When in your career do you think it would be suitable or nice to engage in a coaching relationship with someone where they coach you? So when would work for your career? Is it right now? Do you have a felt need now? Or are you in the midst of a range of study programs and other things, and you think in the future there could be an ideal time? And we're not going to share these. This is for you personally, because it's helpful to pre-think some of the characteristics that you might value in a future coach. I had a senior nurse researcher try to coach me for several years, but we were not compatible. So it was always, we never met. Like we were always trying to meet, but we never actually got to connect well. And it was very frustrating. And I didn't know how to exit the coaching relationship either. So it took me a long time to accept that this wasn't working and that I needed to stop the program. So it's good to think about what helps fit myself with someone else and when might that be useful to me. All right. So congratulations, you've made it through part 1 of today's program. We've had a little bit of discussion, a little bit of reflection, a few stories. So a soft takeoff. Why are we talking about coaching? You know JBI, you know that we're an evidence-based organization. And so we wouldn't be talking about coaching if there was no empirical evidence related to the value and the utility in terms of process and outcome. That's why we're here. That's why you're here too. So let's look at, in this session, let's look at the evidence around coaching. There was a really significant Cochrane review published by a colleague of mine, Noah Ivers, and colleagues quite some time ago. And it was around, actually, it was around audit and feedback. You can look this up if you want to. And audit and feedback can include any number of interventions to promote implementation. So audit itself is not an implementation strategy, nor is feedback, to be honest. But within an audit and feedback cycle, which is a pre-post test process, you can embed change processes. And change processes that improve professional practice often include, discussion between individuals or discussion between groups, may include mentoring, may include coaching. And so we see from this review some interesting evidence related to coaching. And the evidence is this paper. So in the entire systematic review, I went through the whole thing. I read all of it. I read all the references, the results, etc. There was one key paper, which is, as you can see, a randomized control trial where they looked at the role of coaching. In fact, they called it performance coaching, and the topic is enhancing tobacco dependence treatment rates, but the intervention is coaching, okay? So we separate the intervention from the outcome measurement. We can say this reasonably looked at coaching. So we're going to spend a few minutes looking at this RCT because it was the only RCT in the review, and yet the review says coaching is an effective strategy. So we're all very clever people here. We want to know the evidence. So this RCT, what the intention was to explore the effects of performance coaching delivered as part of a multifactorial intervention to see what impact, if any, it would have on improving the way primary healthcare professionals interact with people who use tobacco-related products in order to ensure those people get more questions about their tobacco use, more invitation to quit, or more invitation to use products to help them come off of tobacco. And when you look at it, this is a parallel group cluster RCT. So does anybody know what a parallel group cluster RCT design is? I mean, everyone knows. Is anyone brave enough to say, what is a parallel group RCT? What does it mean? How many groups in a parallel 2 groups. Yep.
For the usual care, compare together with the coaching group.
Yep. Perfect. And what about cluster? Any ideas on clustering? So when we think about RCTs, often they focus on individuals and they randomize individuals. And sometimes they focus on organizations. And with organizations, a common approach is to cluster the organizations rather than individuals. So a cluster RCT is really about batch randomization to sample. Yeah. Good. And here's sort of what they found. Coaching led to more general practitioners, so this is in primary care, offering support using a particular mnemonic. They call it the 5 A's. So where they were doing more assessment, they were doing more advice giving, they were seeking agreement, they were assisting with evidence, and they were arranging follow-up. So 5 domains. And you can see in the results here that coaching in this RCT, good to great, resulted in improved use of asking, do you use tobacco-related products? That's a good question to start with. Assisting, would you like support in order to consider coming off of dependence on tobacco-related products? Arranging, we can set up a program for you, or I can get you access to nicotine replacement therapy, et cetera, et cetera. So these were the results, and you can see the adjusted odds ratios, confidence intervals for that data. We're not that interested in the data, to be honest. It just shows coaching had a significant beneficial effect, and it increased rates of tobacco dependence treatment by primary care clinicians when delivered as part of a multi-component intervention or a multifaceted intervention. So there's something about coaching that works, even for people with a drug of dependence issue like tobacco. So that's interesting, isn't it? There's something powerful about the coaching relationship if it can help people move away from nicotine dependence. So it's a significant effect. What was it that they did? This is the key bits. I hope you can see this online, and my apologies if it's too small to read. Coaching sessions, 1.5-hour supplemental session. Right. So the intervention was delivered as a supplementary or part of a multifaceted intervention, 1.5 hours, 4 weeks after commencement of program, and included individualized feedback. So individualized performance report. You see that second underlined section there? Individualized performance report. And this is a messy slide, but the big circle highlights the interesting thing to me. They used a standard facilitation guide focused on clinician self-efficacy and the intention of coaching. So coaching was intentional. The coaching had goals and outcomes. They wanted to influence 4 factors associated with self-efficacy. So those 4 factors you can see on screen there in the circle, roughly: skill training, personal experience, modeling, positive social environmental supports. So those 4 things were important to the effectiveness of coaching. And I guess as scientists, we want to understand something about what did they do for each of those 4 factors in order to be effective as a coach. And this is why I think this kind of information might be useful either now or later in your career, because people might come to you for coaching. You know, you get a PhD from Chiang Mai, you're a significant person. you have a senior clinical leadership role in the hospital, you're a significant person. People will want to learn from you. You have respected knowledge and leadership. But how would you help them? How would you coach? So let's look at these 4 factors. Here we go. So the first one is skill training. The evidence from this RCT concludes that when we provide skill training, this includes practical procedural care that links to safety and quality compliance. So standardized skill training is a good coaching technique. And remember, we started with coaching is short-term focused. So if you're looking after students, for example, in a clinical area, part of what you might do is take them to a skill lab and teach them a particular intervention or practice and get them to repeat it until you see confidence and competence. So that contributes to safety and quality. Procedural care. What they also found is skills are more impactful than role delineation. And really what that means is it's not about the hierarchy. So where do you sit in the hierarchy? It's actually about how can we use coaching to enhance competence, regardless of position in hierarchy. So we don't need to focus on role definition and role organization and structure. Practical procedural care skill training is more useful than accepting, for example, seniority is associated with good practice. So the more people get skill training, the more confident they become at interventions and procedures. It makes sense, right? This has been your own experience developing into a competent, confident nurse. If you want the theoretical underlying framework for this, it's Bandura's 4 factors associated with self-efficacy and coaching. And that Bandura published that just after I was born, 1977. So Bandura, 1977, Unifying Theories of Behavioral Change is the source, like the theoretical framing for this. And coaching can include use of recommended practices from organizations like JBI, contextual videos, clinical narratives, expert facilitated training sessions, and even printed materials and reminder notes and those sorts of things. So self-efficacy skill training can be done in many different ways. And the more we layer those methods, the better the learning experience, the confidence and competence is increased because it's multifactorial. Do one thing once, a little bit good. Do one thing 3 different ways, multiple times, very good, right? And that, again, I think just makes good sense. So skill training, there's good, clear evidence to underpin why that's part of coaching. The second factor is about personal experience. And this argues that if we're doing teaching, practical and demonstration on procedures, then we have to be good at this ourselves and understand what and how to deliver it. Not only does the person providing the skill need to be competent and confident, we want to broaden the frame of the access for that. So training must be readily accessible to all cadres of clinicians. And you already probably have this. So if you work clinically, you do like a CPR refresher program annual, 6 monthly. How often? Like 2 yearly or?
I do.
Okay. Ah, naughty. All right. So there are those things that we make accessible to all clinicians within our organization. It might be, there might also be specialist ones, but there are some that are fundamental across an institution. And then there are others that are more specific. So if you have a role designation that includes taking blood or routinely doing ECGs, or you have responsibility for blood glucose measurement for patients, maybe you also practice competencies there, and maybe also things that are more formative, like drug calculation, demonstration of knowledge and recency of education. So we can accumulate personal experience through training, through bespoke workshops that incorporate a little bit of theory. So what is it and how does it work, as well as the practical hands-on approaches. And these helping people to accumulate personal experience is a really good fit with Patricia Benner, Novice to Expert. Has anybody read Patricia Benner, Novice to Expert, or you've heard of it before? Yeah, Patricia Benner, Novice to Expert. And it's a very good theoretical fit with the work of Patricia Benner. So personal experience. Somebody who is being coached needs to develop personal experience. Coaching is not a theoretical activity where we just sit down and chat for an hour. If we're talking about going from good to great for clinicians, and this is true in implementation as well, then we need to be able to move into personal experience accumulation, right? Then there's modeling. If I see other people succeed, I see a pathway that maybe applies to me. If they can do it, maybe I can do it too. If they can transform into a nurse leader and become a good implementation scientist, maybe that's a career area that I would be excited to investigate for myself. What that does, when we model good behaviors, it shows other people what they are capable of. And a coach wants other people to see what they are capable of. So that's really vital. Reduces uncertainty about what effective performance looks like. When you see somebody clinically perform a complex skill and they're comfortable, they're confident, they've actually focused firstly on the patient, not the procedure. Have you noticed that? Highly skilled people, they make the patient feel comfortable and relaxed, or even in a high dependency ICU environment where patients are ventilated, sedated, paralyzed, somehow to do that intervention, usually they just de-stress the environment as part of their leaning in to get things done. So I can learn a lot from that, right? Because as a novice, my focus is technique. How do I technique? But if I'm an expert, my focus is my patient, the environment, the technique I already have. My goal setting is actually to create a good environment so the technique goes well. This is true in implementation. This is true in behavior change for tobacco. This is true in the practice of nursing. The more stressful the environment and the more stressed I am about the technique, the less patient care I'm delivering, and the less I can show other people how to do this well. So we want to do this well, this bit. Yeah, no, I won't ask. I was thinking I would ask this question, but maybe we just lead in here. So I think that's pretty clear, isn't it? That's self-evident. Modeling of behavior. People that are junior to us will watch what we do, even when we don't think they're watching. They will listen to what we say, even when we don't think they're listening. And from what we say and do, they will decide what is important. And to try and rephrase that for clarity, the things that we give attention to as leaders are the things everyone else will accept are important. Because you're a leader, if you give attention to something, people will go, okay, that's important. And they will change their focus to bring attention to that thing. You should try this out in your work life and see that it's true. It's profound to experience this as a leader. Start to give overt attention to the things you want other people to give attention to. I find this difficult because I prefer to be interpersonal. I prefer to be liked. I prefer to know people and get along well. But when I sharpen my focus and stay true to my focus, other people start to pay attention, not to me, to my focus. And that's coaching. That's what we really want. So what if I could have anything I want from you as a group, it would be that you do this, but also with an implementation focus, implementation of best practice, right? How do you encourage people to get more focused on implementation of best practice? You have to give him attention to it. You have to look for it in your people, reward it when you see it, call for it when you don't see it. And that's transformative. That's transformative coaching. Does that make sense? Cool. Great. So then I guess we've got to ask, if modeling of behavior is ideal, then what kinds of behavior modeling are supported by evidence? And this is a little bit messy, but we're still within our 4 factors of self-efficacy. So we're still with Bandura from might have been 1977, or might have been different date. So there's a number of different models, and the view is that modeling changes behavior by strengthening people's belief that they can act effectively, especially when models that we apply are relatable, transparent, easy to understand, and can fit our complex environment and our local context. If we try to force a model into place and it doesn't quite work, or we have to skip, then people lose confidence in it. But if we have a model that is relatable, transparent, and adaptive to complex localization, then actually the way we model behavior influences not just skills, but also standards. So people can learn by paying attention to modeling. So we want that behavior to be meaningful. We want, over time, through modeling, the observer, the junior staff person, to start to encode it into their own professional identity and practice. But for it to become part of their encoding or their language and self-image as a health professional, they have to have opportunities to practice it, which is one reason why every hospital, every facility, every university should be engaged in evidence implementation. And modeling is motivating. If I, as a senior, am modeling kind of the behavior I want to see, then I'm motivating people because people pay attention to what I give attention to. That's the nature of leadership. They want to know they're in sync. So I give attention to this, people start to focus on this, and it changes them, it improves them, right? That's true leadership. So lots of really good relevance to healthcare coaching by modeling and using modeling. And notice it's not punitive. It shows efforts, it deals well with mistakes, it allows for self-correction and gradual improvement. So not perfection right from the start, growth, development. And I could say a lot more about this, but nursing sometimes is too harsh. It's not about punitive correction. That is poor leadership, right? In my view, that's poor leadership. Growth and development doesn't come from being a harsh leader. It comes from a little bit of inspiration and hope for the future. Someone's got to be able to see how they have grown. So if I'm correcting somebody who's got poor technique or, their communication skills need enhancement, I don't just criticize what they're doing. I live and show the next step. It might not be the final destination, but it's the next step, right? Because my belief is in them for their improvement, not to be a harsh corrector. Worth thinking about, isn't it? And if you've experienced that model of harsh correction, maybe you can be the person who breaks that cycle and breaks that process. So, all right. So now this is the final factor of self-efficacy. And there's two parts to it. So part A is about positive social supports. Positive social supports. And this is all from the evidence from this randomized controlled trial, right? So the RCT said there are 4 factors associated with self-efficacy, and now we're into the 4th factor. And this first part is about positive social support. So what does social support look like? This is in a primary care clinic, but you can see these characteristics. They've got to be relevant to clinical care. They've got to be relevant to junior faculty as well. Interest, belief, curiosity. If my junior staff want to present at conferences or workshops, they do their preparation with my input, and then they do a rehearsal presentation with my whole team. And we sit there and we give them our true interest in how they've thought through and developed this presentation. We do that because we have belief in their future ability. Regardless of where they're at right now, we have belief in their future ability. And we encourage and develop their sense of curiosity about knowledge and about how to communicate and how to refine and enhance communication. So good, positive social support is not like my football coach. My football coach was bad, right? We don't want to be a football coach like that. We want to be like a good, positive social support, encouraging self-efficacy, skill training, offering more positive beliefs and attitudes is always more powerful than negative. Negative will decrease self-efficacy every time. Positive will build self-efficacy every time. That's really significant, isn't it? So lots of cool stuff, strength-based behavior, feedback. In other words, what you did well, really useful for thinking about explicitly recognizing effective practices. And then if you need to, address gaps using observed behavior linked to clinical standards. Positive social support looks like normalizing challenge and coping models. So helping people see they're not the only one that's had a difficulty, and sharing adaptation strategies, sharing tips and tricks and insights from learned experience through yourself and through others. And this really helps enhance motivation and develop sustainable behavior change. So if I had to summarize this if I had to summarize social support, positive social support in one sentence, I would say this: effective social support in coaching is a combination of empathy, of clarity, of normalization, Normalization. You have to think about what that means. Normalization. And shared ownership. So I'm a partner with you here. I'm not here to observe and punish. I'm actually with you on this journey of self-improvement. And why would we do this effort? Why would you engage that deeply with colleagues and staff and junior staff? Well, it's because we all have a common goal, even across hospital and faculty staff, right? The common goal is the provision of safe, high quality care to patients. That's our goal. And good, positive social support is a useful mechanism for moving toward that goal. You're doing really well. Where are we? We're about 10 o'clock. So we're getting toward a little bit of a break. Okay. But good to have you all engaged so well. Thank you. Yeah, I know. I forgot to start my timer. I normally run a timer to keep myself for you online here. It's still on 0, so we still have 3 hours. I forgot all about it. I get too excited about this topic and I talk too much. So part B of the positive support element is the environment that we offer coaching within. And there's a range of, in fact, there's 4 evidence-based forms of positive environmental support that you might be able to already recognize in the way you practice, or might be things that you start to advocate for in practice, including academic development practices. Protected time and psychological safety. Protected time, very hard to get. But if you value your staff, aren't they worth protected time? And if you value coaching from somebody senior to you, protected time is fairly vital to that process. So if Patraporn is coaching me and I'm here, oh, Patra, there's something interesting on Twitter. I'm not, am I? I'm not doing anything useful. Like, so my phone is down, face down. I can't see it. I'm not interrupted by it. Take the risk on protected time and promote psychological safety so it can be authentic. It should be about clear role expectations and supervisory boundaries. So what are we doing here? Do we both understand why we're here and what we're trying to achieve? It's got to be same. If we have differences at this point, we need to talk through those differences at the start. So we want to understand role expectations and also boundaries. In coaching, short-term, goal-focused, there might be areas in my life that I really want to get off. Do you know the saying, off my chest? So to get something off my chest is to unburden part of my emotional labor or emotional psychological pressure. That's not what we do in coaching. That's more mentorship, perhaps. So coaching is about improving skills and knowledge within a focused way. So, we want to be clear about our purpose and how it's going to unfold. We don't want role ambiguity or lack of clarity. And we need boundaries, reasonably professional boundaries. A coach is normally someone senior. They should not be touchy, right? That's a professional boundary that could get crossed. So professional boundaries matter. We have to just be aware of those. Access to usable evidence and feedback infrastructure. So feedback that's based on templates or standardized approaches, it adds consistency, which adds to the beneficial learning process. inherently a good thing to do. Ideally, they're evidence-based. They can use knowledge to action. They could use audit and feedback, other approaches like that. And when we use evidence and standardized feedback mechanisms like a template that is consistent over time, we're shifting the nature of our coaching from opinion-based discussion to evidence-informed improvement. Right? So standardization of feedback mechanisms and processes helps move to evidence-informed improvement. And then 4B, positive environmental support, includes visible leadership modeling and organizational alignment. This is where senior clinicians and leaders visibly participate in the supervision process, in reflection and in improvement activities. I work with a hospital in Adelaide called Lyle McEwen Hospital. All the senior nursing executive are in mentoring coaching relationships, and they all share the same mission and vision, and they talk about it frequently. They always talk about and love to hear from their staff examples of person-centered care. The whole nursing department is committed to the vision of seeing person-centered care as the model of care delivery. And so they check in with each other and they check in with other staff. It's very visible. Even I'm an outsider, but it's visible. I can see it happening. So leadership in coaching is about being visible in the good things. It's about modeling those, and it's about organizational alignment. So why does this work? This works because if you're coaching someone, you're a leader. What you give attention to is what other people will change to see as important. They might not have seen it as important before, but because you're a leader and you give it attention, that's the message. This is important, right? You don't even have to yell like my football coach. You just have to give it your attention, and people will immediately see the shift. Immediately see the shift. Maybe not immediately change behavior, but immediately see the shift. So if you want to implement some longer term strategies that influence culture in a positive way, start to be visible in the things that you want to see. People will pick up on that. They'll absorb it over time. So these are the attributes of self-efficacy that relate to positive support from an environmental perspective. It's about time, protected time. It's about clarity. It's about tools so that we're not reliant on opinion-based coaching, but it becomes more evidence-informed. And there's got to be consistency of leadership signaling. In other words, people have to see us live what we speak. Live what we speak. Professionally, that is. So hopefully that makes good sense to you. All right, we're going to do a little activity now, and then we've got probably 15 minutes and then a break, short break, okay? So we've said so far this morning, we've said how many factors are involved in effective coaching? 4, I think you said it first. So we said there were 4. What we're going to do is we're going to focus just on the first one. I'm going to show, if it works, I'm going to show you a video. And what we're going to do then is break down the video. So there are 4, but we're going to watch a video. This is on expert peer modeling. And what I want you to do, see those numbers 1 to 3? This is what I want you to write down. When we watch the video, what are the things that stand out to you that the person said, What are the things that stand out to you that the person did? In your opinion, what makes this skill training effective? In your opinion, what makes the training effective? And were there anything that really stood out to you that matters? Extra points. If you can watch the video and then say one thing that worked well and one thing to try next time. So one thing that you thought was really good and one thing you thought could be better. But look at the framing here. One thing that worked well, that's good feedback. One thing to try next time is positive messaging for improvement, right? It's not what the person did badly. You did this very badly. You need to do better. No. One thing to try next time.
Before washing your hands, ensure that you are indeed bare below the elbows. This means that you mustn't be wearing any jewellery and that your watch is removed. Apply liquid hand sanitizer to your hands and rub the palms of your hands together. Then place one hand over the other and rub the back of your hands, interlacing the fingers. Rub your fingertips into the palm of your hand as demonstrated. Rub the gel around each thumb and the area around the thumb. Finally, go around each wrist, ensuring indeed that you rub the gel the whole way round. Keep going through this sequence until your hands feel dry.
It was short. It was specific, targeted, clearly done by an expert. So this is really the sort of thing we would like to see. Okay, so there's a whole range of approaches to coaching that can help people move their practice, their knowledge base or their technique. And it might be clinical, it might be hand washing, but it could be something else. It could be academic, it could be willingness to participate in implementation type work. So the first is motivational interviewing, which is where we ask open exploratory questions. So if I have the clinical leadership role and I need my staff to improve or to standardize practice using evidence, I might propose that we work together in our unit. So to the team, we need to do an intervention to reduce patient falls in my unit, right? So I want to introduce processes that increase safety for patients, but that takes time and effort. And some staff will feel more pressure than others to try and include new evidence-based fall prevention strategies. And if they feel that pressure, they're less likely to follow through and use the best evidence strategies because it complicates their time management. For me to really help move them is not to yell at them like a football coach. That's non-productive. What helps is to understand and to let them speak the concern, right? And one way to do that is to ask a question like, what feels most difficult about this change? But notice the second part of the question. It's very powerful. What concerns you if nothing changes? The first part of the question is, what's your burden? The second part reminds them that we have a professional need to improve patient safety and reduce falls. And they're a part of that. What concerns you if nothing changes? So what this second part of the question does is it actually reduces resistance to change and it reduces ambivalence. Ambivalence means I don't really care, whatever, either or. So this is an open question to explore two sides, both sides of change. Reflective listening, what feels most difficult, and then drawing on the person or the clinician's own reasoning for why the change is good. The second part of the question, really cool technique. So this comes out of motivational interviewing, evidence really from marketing and behavioral sciences. And why it works is that it treats resistance as a signal, not a problem. So it's not that I hate that person. It's not that they're always annoying, always say no. It's a signal. And if I ask that double question, I can reduce defensiveness and increase internal motivation to participate in change. It's a really cool technique. The second is stress-informed reflective coaching. I won't go into huge detail on this, but it enables people to think through a question so they actually identify what their own barriers or concerns are. Before we problem solve, what's weighing most heavily on you now? So and that gets them to reflect on, we are going to problem solve. So that's part of this negotiated process. We're here to problem solve. But before we do that, what's hardest for you right now? What's weighing on you the most right now? And what's good about that is it avoids jumping to rapid conclusions. It gets people to really think well before reaching a conclusion. So that reduces cognitive loading and supports improved functionality and improved decision-making under pressure. So this is a really helpful technique. And then, of course, we need boundaries and boundary-based approaches. So somebody might share with you and you go, look, I'm glad you raised this, but some of what you're describing goes beyond what we can safely do within a coaching agreement. So maybe we need to explore support options alongside our work. This preserves your ethical integrity and practice as a professional. So really, what we're trying to say just with these three techniques, we've looked at 4 factors. Now this is 3 techniques, strategies you could use. Effective healthcare coaching for implementation, for practice change, for improvement in skills, knowledge, capacity, and ability meets resistance with these strategies: curiosity, containment of stress, understanding of mental health concerns, with compassion and with clear boundaries, right? So those 3 techniques together get to the heart of ambivalence, resistance, stress containment, mental health concerns, logical discovery of solutions. So it's really very powerful work. If you were to take anything away from today, maybe these 3 strategies would be one of the key things I'd suggest. So just to recap some of that, effective coaching processes, we want to establish a functional coaching relationship, have a clear plan of action, so it's purposeful. It's not vague. We don't just meet for an hour and chit chat. Clear goals. And look at what are those goals. If it's not working, terminate the relationship. Stop the coaching relationship, either as the person being coached or as the person offering coaching. You can't afford to spend all your time in a pointless cycle that doesn't achieve outcomes. So your purpose in coaching really depends on the abilities of 2 people to build a strong, a useful, a trusting, pragmatic relationship, professional relationship. It's co-assessing needs accurately and co-developing a plan that is tailored to goals, strategic goals, organizational goals, and short-term learning goals within your local context. And a structured, systematic approach can really help with achieving this. So if you want to establish a coaching relationship, you want to build trust and understanding, establish psychological safety, clarify roles and process and context, and develop the ability to signal trust and safety. It might be confidentiality, for example, that everything we say in this session is just between us and does not go any further. We want to think about establishing and implementing an action plan, because coaching is about moving people, advancing knowledge, skills, behavior. So the coaching focus here is co-create clear and achievable goals, preferably because my interest is implementation science and implementation. So link those goals to evidence. When we talked about coaching this morning before the break, we looked at the evidence from good to great. Like, I didn't just tell you coaching is good. I transparently showed you the evidence. Cluster RCT, 15 general practices, showed you the odds ratios for each outcome. Fit for context, support resources and stakeholders. And for us, I guess, to think about how small actions can reduce resistance and build momentum together. So these are important attributes. Then this is sort of like just to help wrap up this session that was meant to finish before the break. Here's the hard bit, I think, is work out how to evaluate progress and establish goals. And if that's not working, to terminate the relationship. So as a coach, you actually, you're thinking about, is this progressing? Are we achieving the intended outcomes within the timeframes that we were expecting? If it's not, and you keep giving to that relationship, you are not able to give to another one. There's an opportunity cost. It's called an opportunity cost. Every time I say yes to one thing, by default, I'm saying no to other opportunity. And you've all lived this. You all live this all the time, right? The opportunity. So weigh up the opportunity cost of whether or not to continue in a coaching relationship if it doesn't look like we're really reaching success. If we're not noticing the person engage and develop the way we would hope. So we don't need a break. You only get one break. So we'll move past this point. This is a model that you might already know of. Does anybody know about the GROW model? Anybody use this model? Okay, so maybe it's new. That's kind of nice. There's a lot of models for coaching. There's a lot of models for everything because academics produce models all the time. And it's not necessarily about which one is empirically the best. All theories, models, and frameworks do similar things, right? They provide a form of guidance, and you really just select the one that has, cultural congruity, utility, that kind of thing. So the purpose of a model and a methodology around coaching is that it provides a structure and some guidance for the process. This is a very simple one. It's called Goal, Reality, Option, Way Forward, or WILL. And so it's called GROW. And this was developed in the 1980s. It's pretty straightforward, I think. It provides a framework. That's the whole point, to develop goals around our focus and then to start to address reality options and way forward around our core focus. So the model begins with setting of goals that are specific and measurable outcomes, because we're coaching short-term, strategic, focused. Coaching then is about exploring the current situation, the current reality of the person's situation, including looking at, all right, so if there's a knowledge deficit or a skill deficit that we're trying to improve confidence and competence in, then what are the resources and barriers that are part of the clinical picture here? And for me as an implementation scientist, what are the barriers, the enablers, the resources available to facilitate better implementation of evidence into policy and practice? So once there's a bit of a picture, we've got an agreed goal, we've evaluated the local context, so the reality of what's available to us, then we can move on to explore options that overcome barriers by drawing on available resources to help address those. So exploring options is about overcoming identified obstacles. It's not a vague process. It's really targeted and specific. So it's hard actually to identify the true barriers at times. But hopefully we can, by good communication, identify the barriers and then look at what are the available options. And of course, finally, the way forward is the action process. So the coach helps the person to commit to taking action through specific measurable tasks and timelines, particularly for competency and skill-based training requirements. It's useful to have specific measurable tasks and timelines. I set a task for somebody I was coaching in Adelaide, and it was mutually agreed. We had a meeting. I really listened to what they were saying. I gave them feedback from what they said. They agreed that that was what they'd said. And I gave them a goal. Your goal before our next session is to have one conversation with your senior research director. And this is the conversation that we agree you need to have. And they didn't do it. So I no longer coach that person. But we had a clear goal. We understood the barrier and the challenge, but they didn't want to do it. So now we're not involved in coaching. But that's broadly what coaching is. Have a try at this. You can do this online too if you're online this morning. You're a nurse unit manager. Is that what you call a ward coordinator? Is a nurse unit manager head nurse? You're a head nurse. And you want to improve communication during handover, nursing handover. Currently, handover runs late, key information is missed, and staff feel quite frustrated. So how could you lead more effective, concise handover to improve safety and team satisfaction? So here it is. The goal: improve handover, shorter, clearer, safer, more engaging. Is there anything else you would do? Just jot it down. The reality: handover runs late, information is missed, the team is frustrated. This increases risks to patient safety. Do you have any experience with this? Are there other realities that relate to this? If so, jot them down. You don't have to use this bar, it's just a mnemonic, so don't worry about that bit. But what are options that might help fix one or more of these problems? This is where you should focus your attention. What are the options that would help fix the problem of running late, missing information, team frustration, patient safety? And then how might you use an option? Right, 5 minutes just to think about that. Well, that's 2 minutes. Does anybody want to share? What are some options for resolving these problems? What might some options be? Who's got an option? Who's brave? Who's brave enough to share? Sorry, can you use the...
I think, in my opinion, one of the option could be maintaining a specified time, like a duration of time in which the handover should be finished. So that could be one of the option.
Yeah. Better time management's a good option
better
here,
time
isn't it?
management.
Yeah, well done. Other options?
It should have like a system for the communication, productive communication.
Yep.
Like as you mentioned, it's about the IS bar. It's like a systemical chip handover communication.
Yeah. Yep. That's also a good solution.
For my opinion about this, maybe have a separate in the two team, because a lot of patient, maybe the information is not clear. Yes, thank you.
Yep. Okay. So multiple teams as a strategy, and potentially we could combine those. So we could show leadership by better time management, by bringing in a rubric that helps people. So that's why like ISBAR is a kind of a rubric that guides what information to hand over. Or if we need to, we could sort of break that down and look at different team-based processes to improve efficiency. And maybe we could try all three at the same time and give our attention to that. And because as leaders, we give our attention, everyone starts to focus here and improve their own work as well. Yep. No, that's really good. Thank you. And that's a fairly simple example of using GROW. Like that's not overly complicated. G identifies what we want to resolve, what the problem is, how we could conceptualize it clearly, because if we can't clarify it, we cannot fix it. So as a coach, we want to clarify because we want to be able to fix. We want to deal with the reality of what's occurring right now and think about, you know, barriers and resources, and then put them together into a functional plan of action. That's what good leaders do. Very good. And so just to wrap up this little session, there's a lot of promising interventions that enhance leadership development and support decision making and change management. Coaching is one of those. It's a key one, a key attribute-based process, which organizations can adopt. It would be good to see, for example, an organizational-wide approach to adoption of coaching, so it becomes considered an integral part of how we lead organizationally. It's okay to do it as an individual, but it's powerful if there are other leaders like you who are also using the same process. Our impact goals are to facilitate development in implementation. This relates to leadership skills and behaviors, using coaching, and in general, average durations around coaching. See, you know, at the start we said it's time-based, time limited. So 4 months-ish, but it involves in a range of ways of keeping in touch. In-person meetings are powerful, other strategies as well. And frequency for effectiveness varies from once a week to once a month, probably depending on what my goals are and what I'm trying to achieve. So when we use coaching, we can develop this large list of improvements in outcome data And this is supported by qualitative and quantitative evidence. People will improve in confidence, resilience, reflection, role clarity, leadership, reflective leadership, and a whole range of beneficial outcomes from coaching. So this has got good quality evidence to underpin it. What we would like to do now is start to look in a little bit more detail at using Grow to develop clinical leadership capability via structured coaching approach. So this will probably take most of the rest of our time. And we have to think about the goals that we want to achieve with coaching. So this is like more of a deeper walkthrough of Grow. Setting goals. Have a clear clinical leadership goal. This comes from, discussion between a head nurse and junior nurses. So there's clarity around what is the need. And it might, for example, be that we have to provide better leadership during handover. In the goal phase setting process, the senior nurse mentors a junior nurse. It might be after a patient deterioration event. So have you ever had junior staff who struggled to cope after a significant adverse patient event? Has anybody experienced that, where junior staff or students, some of those can be really shocking. I haven't been in clinical practice since the 1990s, but I still remember 2 patient deaths, actually 3. One was on night duty, and I was the only RN, and a person aspirated a huge volume while I was trying to do CPR. So every time I put them flat on their back, because compressions are vital, they would regurgitate. Huge volumes of liquid were coming out. It was on the bed, it was on the floor was slippery, and I couldn't clear an airway to do CPR. So I had to just, in the end, keep them on their side the whole time. No compressions, no oxygenation. There was a high dependency patient who died when I was a student, and I remember everything about that man. And then I remember the first time I had to prepare a deceased person to be taken off the ward. And the nurse knew I was junior, and she said, get the procedure manual, go to this page, follow the procedure. And then she completely left me alone. Like, I was scared out of my brain over that experience. And it took me an hour and a half to prepare this person because I was intimidated and by myself. And it was really nerve-wracking. So that was definitely an example of just zero support through patient deterioration type events. And sometimes we might ask junior nurses to take responsibility for supervising students through something without giving them time to really do that well. So there's lots of challenges. But if we're going to have clear goals and you were to pick one of these strategies, part of it is who's going to benefit? Well, I don't think that's hard to answer. The person we coach will benefit, we will benefit, patients will benefit, the organization will benefit, right? So a lot of mutual benefit there. But how will we measure success is more qualitative, probably. So it's useful to think about how do we know? What do we want to achieve? What's the goal? Because if we know the goal, we can measure success. How will we know this goal has been met? And who is this goal mostly about supporting? If we could, we would have one clear, concise, measurable leadership goal agreed within 1 to 2 sessions of commencing coaching. So reality is this, it's what's happening now. It's about exploring the current situation, including allowing people to talk about the negatives. But, you know, we've already talked about how you frame negatives, haven't we? So what's weighing on you the most right now? And not but and is more powerful as a way of engaging. One good strategy to develop yourself as a leader is to stop using the word but and start using the word and. So what is the current situation that's occurring right now in a neutral way? And what would concern you most if we did not make this change happen, if we did not achieve this together? Not but, what would? But is opposition and is partnership. Powerful word. So this way we can, by exploring the reality, whether it's handover, patient deterioration, or a novice supervisory experience, we can start to unpack what are the barriers that exist right now. So some will be about time. It's always about time. But it will also be about culture, skills, resources, and felt individual capacity. And then we can go, well, yeah, those are the barrier parts of our current reality. And what are the available resources? And often we forget this piece and we just rely on our own resilience, but you don't have to. You work in complex organizations with good resources, including other leaders. So what about evidence? Does evidence help us with this? That hand washing video was based on evidence. What about policies? Are there relevant policies that we can lean on? When you're junior, policies are helpful. And other mechanisms by which we can provide feedback. So barriers exist and enablers exist. So getting the person that we're coaching to help focus on the enablers is really good for their professional growth. What we achieve if we do this step of reality discussion together is we develop a brief summary of we already know the goal, step 1. Here now we know what are the key constraints and the enablers and the evidence. Isn't that a cool picture to be able to take out? Like, that's really helpful. Then step 3 is options. Now that we have this picture of the goals and the reality of the current situation, we can really start to strategically, in a focused, deliberate way, explore the options. And that might involve brainstorming, encouraging creativity, exploring multiple options, good coaching conversations, thinking about how, as a charge, do you say charge nurse or head nurse? Head nurse. Head nurse could provide leadership support, engage with the wider staff community in an appropriate way, and identify small low-risk actions that could be tested first. We could also think about what does an evidence-based approach look like. So in terms of exploring, this is like brainstorming. Has anybody been involved in brainstorming? Yeah, one of the first rules of brainstorming is no criticism. Every idea gets written down, right? And so that's a little bit like this. It's not about judging ideas as they come out, because that suppresses ideas. It's actually about enhancing and facilitating by not judging ideas. And even focus on This will sound odd, probably. Focus on quantity, not quality first. Get the ideas, get them all. Filter for quality, applicability, feasibility later. Don't focus on quality early. It's a mistake to focus on quality because it narrows the thinking and it locks us in on one idea that we then start to explore. A coach should be more confident than that and should push for more ideas. Yeah. So no judgment and really open to quantity over quality. And that gives us a much stronger basis for planning the way forward. Planning the way forward is where we select an action, assign responsibility, set a timeline, and anticipate the barriers around the timeline, which is pretty good. Now, I'm just going to go back now. So I've walked through this with you. I'm going to come back to a goal, and I'd like you to spend 10 minutes. Pick one of the three that you can see in a group of, say, 1, 2, 3, 4, 1, 2, 3. We could have 4 groups. So Annie, can you be part of this group? Thank you, ma'am. And then you're a group down there, you're a group here. 1, 2, 3, 4, 5, 6. So you 4 down the end are a group, and you 4 here are a group as well. Yep. So you guys have to huddle together, get close together. You're going to select one of these and then step through grow with it. So select a scenario, define how success will be measured. Okay. Who will benefit? How will we know it's been a success? So 2-minute group discussion, nominated speaker will feed back to the whole group. You have 2 minutes. Go.
We choose the last scenario, the senior nurse, while the supervise a nursing student. We realize one situation, the nursing student facing to needle injection. Yeah, when they practice, because especially we set up our goal is decrease the nursing student in needle injection rate. It is our goal. And really situation, we didn't search the evidence, so we set up a scenario. This hospital has a high nursing student injection, needle injection rate, and it is our real situation. And options, we brainstorm leadership. We ask our senior nurses, make a meeting and discussing how to figure out this situation. We teach them about standard practice skill and how to calm down when they facing some HIV patient, maybe they facing nervous, build up their resilience when they doing the practice. Yeah, like that. And we reflection after our training, we reflection our this practice and observe the students practice where they practice the daily practice and also evaluate whether the student needle injection rate decrease exactly. Yeah, the nursing student will benefit in this program because they protect themselves, and also our hospital benefit from this program because we protect the student to also protect our patient. Yeah, to make up the patient safety.
Superb. Really awesome. Well done.
Thank you.
Team 2, who's your spokesperson?
So we selected the scenario, the point number 3, that the senior nurse coaches. Okay.
Excuse me. Lovely to see you, but excuse me. Okay, thank you.
Okay, so as a team, we selected the scenario number 3, the senior nurse coaches a junior nurse to take responsibility for supervising a student nurse. So the main two, so identify who benefits. So this is like a kind of system, a channel in which three persons get the benefit, like the student nurse and the junior nurse. The student nurse get the direct benefit, like while when the junior nurse guides or takes the responsibility to supervise a student nurse, so the student nurse and junior nurse both get the benefit. And the indirect benefit is that the senior nurse could also get the benefit, because if the junior nurse guides or supervises the student nurse correctly, that means the work of the senior nurse or the coaching of the senior nurse was successful. Yeah. So it's like a system, a channel in which uh, all of the nurses, senior nurse, junior nurse, and student nurse get successful. Yeah. And also there is a direct benefit for the patient safety. That means the patient safety is well maintained here. And also it is a benefit to the whole team, the whole unit. Yeah. The whole unit. Yeah. And to the hospital. And as Emily said, like it is a benefit, it is better for the quality improvement as well. That means the quality improvement is improved. And decide how success will be measured. So the success could be measured by taking their feedback, that how the student nurse felt when he or she was supervised by junior nurse. So we can measure the success like this by getting their feedback, collecting their feedback.
Round of applause. Sarah, your own special choir. So, thank you. I really love this answer because you unpack the whole picture. Like we talk about coaching, and in my head, I'm actually thinking one-to-one. In my head, I'm thinking, yeah, good. Thank you. Good coaching. Good coaching. Thank you so much. When I think about coaching, I'm kind of thinking one-to-one in my head, or 1-to-2. But using Grow, you have unpacked the entire organizational benefit. It's practical, but it's cultural, and it benefits everyone in the system. That's really impressive development. Like, well done. Really, really great response. Now I'm expecting amazing things from this team. Over to you guys. Which scenario? No pressure. Amazing things.
For our group, we select the first senior RN, the second. Sorry, the senior nurse mentor a junior nurse after a patient deterioration event. Yes, we for the second question, identify who benefit. First is patient safety, and second for nurse, not only the junior nurse but also the staff nurse, and the second for the hospital, because when the event occur, they have a loss of the cost for taking care of patient. And for the third, how success will measure, we measure two. The first of all is the process. We measure about the uh, problem solving, and the nurse confident, and the second for the outcome, such as the incident rate. Thank you.
ไหนคะ Okay, for our the last group, we are select the situation one about a senior RN support a junior nurse to step into the informal leadership during shift handover. Traditional, there are 4 steps involved in the modeling of the behavior, and it is benefit both of the senior and junior. And we select from our short limited time. I review literature with my friend. Okay, thank you. We select 4 factors for the promoting self-efficacy. Consists of the skill training. The senior can train the junior in the correct way. How to do those. And number 2 is about the personal experience from the senior. Senior can teach. From my way, I deal with like this. The third one is about the modeling behavior and form review literature too. It consists of 4 traditional 4 steps to involve the modeling behavior. First is about the attention, 2 retention, 3 reproduction and motivation, and the last one of the self-efficacy to add more the self-efficacy of the junior. It is social support. Okay, that's all. Thank you.
It's called positive discrimination because we are few. We are minority. Well, I mean, that was excellent. And I really love the way you embraced that. Thank you. So what's our we're not finished, sorry, but we are going to look at what's the key takeaway from talking about grow as a little strategy. Coaching is goal focused, performance orientated. Ideally, it's a little bit short term. It shouldn't be 5-year coaching related. That's a problem. Unless you're a tennis superstar. Clinical coaching for evidence implementation, for care transformation, for skill and knowledge acquisition, and for development of future leadership potential is short term, it's situational, it's structured. We need a structure. Otherwise, it's mentoring, not coaching. And it's really suited to, have you ever had a corridor conversation? Like, or you're in the washroom and you have a quick chat with someone about something? No one chats in the toilet, do they? Ignore that bit. But, oh, you all do. So you can have a really brief conversation where you just go, hey, haven't seen you for a week. How are you going with? Open-ended directive. How are you going with? Open-ended directed. Doesn't have to be 20 minutes of protected time every time. So in using grow as a coach, if you're the coach, you're providing structure, you're keeping a focus by using grow on clarity and on action. Coaching without action is not coaching. It's just talking. So action. And it helps to remove barriers and to test and explore options. The action doesn't always have to be perfect and immediate. Coaching is about developing somebody over a bit of time in a focused way, okay? So those are the main kind of takeaway messages that I hope you get by exploring coaching together. And it's great to see the way you did that together as well. So there's another interesting approach to looking at coaching, and in the last, I'm going to go right to the at 12 o'clock timeline here, maybe 2 minutes past. There's some interesting things about coaching. So everyone explores it in a slightly different way. And we'll spend a little bit of time looking at what's called transformational coaching, positive coach. I will say, if you're not being positive and somebody's not changing, it's not coaching. It's something else. And you should reevaluate what you're doing and why. So they call it transformational coaching. To me, I think it sounds like coaching. But here we go. Let's have a little look. So positive health or transformational coaching is the same. It's about addressing gaps in current healthcare by integrating evidence-based disciplines, drawing on positive psychology, health psychology, lifestyle medicine, and grounded in the social sciences. So grounded in positive health sciences. There is a component of understanding about complexity. So complex interventions and moving through complexity using leadership knowledge, behaviors, practices in order to have a positive effect as a manager at my level as a manager for the organization and at different staff levels. Like using the GROW model, transformative or action-orientated coaching or positive health coaching is more useful, more beneficial if it's aligned with the individual's perceptions of what their needs are as well. So this is a little bit about it. The cognitive frame for transformative coaching, it's not necessarily based on a singular model like GROW, but it's about understanding the individual and how their learning experience can be unpacked within the framework of an organizational need or priority. And it might include verbal coaching, action-orientated learning, so that's skill-based knowledge transfer, the development of reflection and reflexivity in practice as well. So it looks a little bit like this slide here. There's 4 broad levels to the action learning or the transformative coaching model pyramid. This is about addressing learning goals within organizational settings, but that they're applicable to the individual. And so they talk about what is the tacit level. The base of the pyramid is always the tacit level here. And at this level, you know, it's about problem solving and implementation of solutions. Level 2 is really not so much about solving my immediate problem, but helping me frame the problem or challenge that I'm facing within an organizational context for my setting. So it's not necessarily teaching, but it's me developing the ability to self-teach, to self-educate. So learning processes by reframing. Level 3 learner goals incorporate the tacit and scientific goals. But here, my development through coaching includes the ability to set my own personal learning goals, have an emphasis on reflective learning. So what I saw in that video about use of alcohol hand gel, were there some good tips that I could actually inculcate in my own routine practice or in the way I, so that's a very reflective question. So this ability to emphasize reflection within my own learning style demonstrates that I'm not just collecting knowledge, but actually able to assimilate that knowledge into my thought processes and into my own professional perspectives. And then if I'm doing that, I'm moving beyond simply experiential based learning and able to integrate what I'm doing and developing as a coach or as a coachee into personal and organizational transformation. So coaching should be useful to individuals, but not only to individuals. to individuals within the context of the organization within which we work. I don't know if that's helpful, but sometimes a little bit of a visual is a little bit helpful. Yeah, it's probably not helpful, is it? But anyway, transformative coaching then can work well for senior or emerging leaders. It's helpful for role transition. So if you're a great head nurse in, say, pediatrics, but then you move to a new area, what happens? Patricia Benner, novice to expert. You actually go down a little bit back to novice, not maybe novice level, but you know, there's more learning to be done rapidly for that transition, isn't there? So role transition is an area that's really helpful. And if you get transitioned into a new role, maybe you should seek a coach. Or if one of your staff gets promoted and they're transitioning into a new role, encourage them to try and find a coaching relationship in that new department, that new division. That'll strengthen their connection with leadership and help them a lot. You know, ethical leadership, dealing with moral distress, dealing with students who feel overwhelmed, staff who are struggling. And when we engage with people through these kinds of professional relationships, it is still interpersonal, and we're valuing the person in a way that actually strengthens them. It increases resilience. It decreases, and there's evidence for this, it decreases risk of burnout. Why? Because it adds a sense of meaningfulness, sustainability to their professional development and their work capacity. And work gives us meaning. Work gives us culture. Work gives us socialization. Work gives us purpose. So these are really good for retention of staff, good culture. In my time at Royal Adelaide Hospital as a junior clinician, I worked in one ward with brilliant nurse culture, always learning orientated. My experience was, this is in cardiovascular unit, step down from surgery. Every patient was monitored all the time. So every patient had their own dots. They were always, you know, the rhythms were always on screen. As a student, one of my jobs was to make beds. And so I was making a bed, and the senior nurse walked in and she goes, "Craig, what are you doing?" And I was pretty proud of myself. So I said, "Well, I'm making the beds." She goes, "While you're making the beds, are you checking the screens for rhythm?" And I said, "Oh, no, I'm not." She goes, "All right, look at bed 2 with me." She didn't say, "You missed this." She said, "Look at bed 2 with me." And so we went over there and I could see the rhythm. I knew it wasn't sinus. I knew enough to go, this is not sinus rhythm, but I didn't know what it was. And I didn't know if it was dangerous, imminent, or just mild. Like, I didn't know those things. She talked me through the rhythm right there. She goes, "The beds aren't important. Watch the rhythms if you're in the room. Watch the patient if you're in the room." And it taught me something really valuable. It was like a 45, maybe 1.5 minute coaching session. You know, she could have really been mean to me if she wanted to. It was justified, but she wasn't. She reminded me why I'm there. And it really gave me an inspired idea of what nursing could be. So, you know, we can get wonderful things out of good experiences. I'm sorry, I talk too much, don't I? So one of the good things about microcycles, like that example I just gave you, that was maximum 1.5 minutes. I didn't learn the rhythm in 1.5 minutes, but I learned that I need to look at the patient. I learned that I need to check the rhythm. That's a valuable step, right? That was my step. So proven quick win increased my motivation and my confidence. That was an awesome experience. It was immediate application to current relevant work issue. I was in the bay with 6 patients. I learnt that I should be watching the screen and the patient, not the bed. So lots of benefits. Lots of different approaches to cycling as well, to think about how, when, and why we should offer coaching kind of advice. All right, we're going to compress this more into 20 minutes, but I want to try something unusual, and it needs you to be a little bit brave. But if you don't want to be brave, you can opt out, okay? So this is a true coaching moment. You can opt out. No need to participate. Here's what I want you to try and do. Using 1 or 2 photos on your phone, tell a story about how a changing perspective can inform your leadership thinking. Either a photo from your phone or a photo off the internet on your laptop. If you don't want to use your phone, a photo that tells a story. So what I mean by that is I gave a workshop a while ago where I had 2 pictures. One was an alarm clock and one was a beach. What does an alarm clock tell you? What does an alarm clock mean? Get ready. It means get ready. It means get up. It means action. Often it's not a nice noise. It's a little bit stress invoking, right? What does a beach mean? Relax. Right. So an image that helps think about changing perspective. An image communicates. Okay, that's what we're saying now. So find an image that could relate to you transforming your leadership thinking. Google images, or if you're brave, an image on your phone. In the same groups as before. And 5 minutes, okay? Do you understand? Do we understand? Yep. Okay, so same groups, image. Each find an image and share it with each other. All right, now we're listening. We put our listening ears on. Boom, boom.
Good morning, everyone. In my group present about the my picture the group Phang Khung. Do you know Phang Khung? Popular in the social. พังคุงเนาะพังคุงเกิดจากตอนเกิดมานะครับแล้วก็คุณเกิดแม่ของมันก็มีปัญหาเรื่องของสุขภาพไม่สามารถที่จะเลี้ยงได้พังคุงก็เลยถูกเลี้ยงโดยคนนะครับโดยพี่เลี้ยงซึ่งพี่เลี้ยงก็ใช้ตัวตุ๊กตามาแทนแม่แล้วก็เลี้ยงตั้งแต่เล็กๆเนาะตอนณปัจจุบันนี้ก็ประมาณสัก7 เดือนแล้วซึ่งก็จะพยายามให้พังคุงสามารถปรับตัวได้ในส่วนของสภาพแวดล้อมที่เหมือนกับลิงทั่วๆไปตอนนี้ก็เลยเอาพังคุงเนี่ยออกมาอยู่กับกลุ่มฝูงลิงแต่พอมาอยู่กับลิงเริ่มต้นก็ปรับตัวก็ยังเข้ากับกลุ่มไม่ค่อยได้รับการปฏิเสธเนาะจากผมไม่ได้เปิดครับอาจารย์ผมไม่ได้เปิดครับโอเคนะครับก็เลยเรียกว่าแรกๆพังคุงก็ได้รับการปฏิเสธจากกลุ่มไม่ว่าจะเป็นผู้นำฝูงหรือว่าเพื่อนต่างๆก็ไม่ให้เข้ากลุ่มนะครับพังคุงก็จะโดดเดี่ยวแล้วก็อยู่กับตัวตุ๊กตาที่แทนแม่ที่ทำให้เขารู้สึกว่ามันเป็นรู้สึกอบอุ่นนะครับแล้วก็รู้สึกว่าโอเคนะครับแต่ณปัจจุบันก็คือตอนนี้เขาปรับตัวได้โดยมีตัวรุ่นพี่นะครับที่มาช่วยปกป้องดูแลเขาให้เขาสามารถที่จะปรับตัวได้กับกลุ่มเพื่อนนะครับซึ่งอยู่ในช่วงของการกำลังปรับตัวนะครับขอบคุณครับ
แชร์ภาพนะคะเป็นภาพที่ไปร่วม อันนี้ ไปร่วมโปรเจกต์ที่เกี่ยวกับเรื่องของตลาดนัดสุขภาพนะคะซึ่งเป็นการรวมกันระหว่างเครือข่าย8เครือข่ายที่เกี่ยวกับด้านเช่นผู้สูงอายุค่ะเครือข่ายของคนพิการหรือว่าเครือข่ายของผู้นำด้านสุขภาพซึ่งเขาจะทำงานเกี่ยวกับเรื่องของธนาคารเวลานะคะซึ่งภาพนี้เองนะคะเป็นภาพตอนสุดท้ายที่เราถ่ายตอนเสร็จโปรเจกต์นะคะซึ่งเป็นความร่วมมือกันระหว่างภาคีเครือข่ายนะคะซึ่งนักศึกษาเองก็มีโอกาสได้ไปร่วมเป็นโน้ตเทคเกอร์ในตรงนี้นะคะซึ่งความรู้สึกที่ได้ร่วมจากกิจกรรมนี้นะคะก็คือว่าเรารู้สึกว่าเราเป็นส่วนหนึ่งนะคะที่เข้าไม่ได้เปิดค่ะไปเป็นส่วนหนึ่งนะคะที่จะเป็นในส่วนจิ๊กซอว์ตัวเล็กๆในการที่จะขับเคลื่อนให้โปรเจกต์นี้สำเร็จได้นะคะทำให้เกิดความไม่ได้เปิดเกิดทั้งความภาคภูมิใจนะคะซึ่งจะเห็นได้ว่านะคะจากรอยยิ้มท่าทางนะคะตอนสุดท้ายเรานี้นะคะที่ทำให้จนสำเร็จงานนะคะสรุปงานออกมาในการทำกิจกรรมครั้งนี้ค่ะประมาณนี้ค่ะ yeah this project
It's okay. My Thai is very good.
oh my god yeah only one sentence this project we are not alone yes
The problem with leadership, like parenting, is it cannot be measured on a daily basis. It is like exercise. I can give you all the science and numbers of people, that prove that exercise is good for your health and helps you live longer, and you might be compelled by my science, and you'll go to the gym and you'll come home from the gym and you'll look in the mirror and you'll see nothing. And you'll go to the gym the next day and you'll come back and you'll look in the mirror and you'll see nothing. Worse, you're in pain, And the problem is because you can measure the pain easily and you can measure the time you're spending but you don't see benefit, you might quit. But if you look at a picture of yourself 3 months from before, you're like, I can't believe I ever looked like that. There's not a single person here that knows on a daily basis if you're a good parent. You have no clue. You get glimmers of hope when you see your child accomplish something. You're like, I'm doing something right. You catch your kid reading under their blankets late at night. It makes you feel good, You really will not know if you've actually done a good job for 30 years. Right? But you have a sense of what a good parent should do, and it's done whatever you do is done with love, and it's done with the absolute obsession with the care of this human being. The one characteristic, and I've only been able to find one, that I'm absolutely comfortable saying that all great leaders have, only one, is courage. Because sometimes being a leader means you have to go first. In fact, that's why we call them leaders. Right? In other words, everyone in the organization knows what has to be done, but who's going to volunteer to do it? Most people go, just wait and see what happens. It's management, It's their problem. I don't have control over the CEO. I'm not the CEO. You are not a leader. Leaders are the ones who say, I could get my head cut off here. I'll give it a try. And what ends up happening is others follow. But if you get your head cut off, then you have to go find another job. That's the risk you run. Leadership comes at tremendous risk. It's all about what you see the objective. And a good parent doesn't see the objective as get a bigger house. A good parent sees the objective as look after my children. A good CEO, good leader sees their objective not as accomplish the mission or grow the bottom line. Those are all good things as a result of but a good leader sees themselves as, how do I get the best out of my people?
So Simon Sinek summarizes what we said with our final group activity around bringing together imagery and human development through coaching, like looking forward, people-orientated, goal-orientated, shared vision. From an implementation perspective, implementation succeeds and coaching works, not because we ask for people to comply with best practice, for example, but because we help them to care. Coaching creates the space where values, evidence, and daily work can be aligned in a meaningful way. Coaching turns implementation, or clinical leadership, if you like, from a technical task into a human task. It helps clinicians to translate evidence into action, uncertainty into learning, and intention into consistency. These are incredible outcomes that we can achieve. Coaching conversations are a signal of value, professional value. What I signal tells people what's important to me. And if I'm a leader, they adopt what's important because they see the priority spoken and lived. Coaching conversations tell people whether improvement is about pressure or purpose. And the synopsis of what Simon Sinek in that last video says, it's about purpose, not pressure. We're not trying to add pressure to squeeze more out of people. It's about giving purpose, helping people swim for themselves to see the world that they live in. That's our purpose. So that's our session on coaching. Thank you so much for your time, your energy, the gift of your knowledge and your enthusiasm today. I think I owe you the applause. So thank you.